I'm just going to get my IT up. Thank you. Do you have another USB port? Thank you. Thank you. Good morning, everybody. Thank you for your patience. I will be talking in two topics. And I would like to ask, I'm going to provide, of course, my email address and my contact information. If we can focus on the lecture and not videotape them, please, with your cell phones. And one reason is because I want your attention, but two is because also I have research data that's not really sort of publicly known, if you will. So the investigators will probably not want recorded. And three, also, in order to record patient information, any kind of patient images, I need to go through the proper channels with paperwork at my hospital. So I would appreciate that. But of course, if there are any questions, know that I'm always available to communicate with you. Okay, so thank you for your understanding and cooperation. So first topic of mine is inflammatory breast cancer. So let's just look at this one image, right? It's something that we kind of all know when we see it. You feel it, that this is a big cancer that is alarming, that is clinically significant. We have this kind of pit in the skin of the breast. We know this as kind of pitting edema, the peau d'orange appearance of inflammatory skin, the thickened orange rind, peau d'orange, classic for inflammatory breast cancer. Clinically, in terms of how these patients present, these are considered locally advanced cancer. It occupies a big part of the breast, usually greater than a third. The breast is swollen, there is rapid onset of disease, and again, the classic skin changes. With the diffuse edema, warmth, there is often pain, induration, and that classic orange rind appearance. Now, clinically speaking, the prognosis of such patients is worse than if it were a non-inflammatory breast cancer of the same size and nodal status. Meaning, let's say you have a triple-negative breast cancer that's stage 3C. But with inflammatory breast cancer, even though you have the same triple-negative breast cancer, same biomarkers, same amount of nodes involved, just the fact that it is an inflammatory breast cancer is worse than if it were a non-inflammatory breast cancer. Lymph node metastases are very common. 70% or more may have regional nodal metastasis at the time of diagnosis, and you know what regional nodal metastasis mean. We talked about that yesterday. That is the ipsilateral axilla, internal mammary, and or supraclavicular. And unfortunately, these patients also have early systemic diseases. Diagnosis, we know that is often done by skin punch biopsy, and here's one histologic slide of a positive case where there is a tumor involvement as shown in this skin biopsy. And what we're looking at here are these, the white arrow here. And they represent tumor emboli in the subcutaneous tissue, which is one of the classic findings histologically of inflammatory breast cancer. So that's dermal lymphatic involvement by tumor, a rather diffuse process, no longer focal. You can get lymphatic tumor emboli, as you can see with these purple structures here in these histology slides. Or lymphovascular invasion, and this is the histologic example of such. Now, by definition, this is fairly advanced disease, stage T4D or 3B, and that's in the TNM staging system, of course. The American Joint Committee on Cancer, TNM. Yesterday we focused on the N part of TNM, which is nodes, and today it is the T part, the tumor part. Primary tumor size, of course, helps determine T part, but also the involvement of the adjacent structures. So inflammatory breast cancer, we need to think about the T stage. Now, when it's T4A here, that means that you have direct extension to the chest wall, okay? But note that chest wall is defined as the ribs, serratus anterior muscle, and the intercostal muscles. Pectoralis muscles is not a part of the chest wall per se, okay? Again, chest wall is ribs, serratus anterior muscles, and intercostal muscles, not only the pectoralis muscles. That's T4A. T4B is when you have direct involvement of the skin, versus T4C is both the direct involvement of the skin and the chest wall. So T4C is kind of a combination of T4A plus T4B, versus T4D, which is the most advanced of the grouping that we're talking about, is your inflammatory breast cancer. This is all meant to say that inflammatory breast cancer is the most extensive of the locally invasive disease, okay? And that by definition will give you stage 3B, which is a relatively high stage. So what does it look like on imaging and mammography? I think of this as primary and secondary findings. So primary findings, you have skin thickening, trabecular thickening, diffusely increased breast density, global or focal asymmetry, and you can also get irregular or spiculated masses. As you can see here, this MLO mammogram on your left is a very classic manifestation of inflammatory breast cancer with the diffuse skin thickening, the increased density, the global asymmetry. You also can have associated findings in mammography. Lymphadenopathy, a lot of times. You can see on the axilla in about half the time on mammography. Distortion, nipple retraction, calcifications is relatively uncommon. You can see it, of course. I shouldn't say relatively uncommon, less than 50%, so it's not as common as the other findings, but of course calcifications is one of those findings as well. Now on ultrasound, you kind of see what you think you can see on mammography. That is, but the findings are usually a lot, not just one. Generalized diffuse, you can have multiple. You can have skin thickening, and you do have skin thickening, right? Because that's sort of the definition of inflammatory breast cancer. Defined as greater than 2 millimeters, edema, diffuse subcutaneous hypo or hyperechogenicities, representing the edema and dilated lymphatics, masses, which can often be mammographically occult. Most of the time, they are mammographically occult, greater than 90%. And they appear as irregular hypoechoic shadowing, just like what you expect a breast cancer to be, multifocal, multicentric, multiple, more than one quadrant. And on MRI, again, the skin thickening, but on MRI, because you're giving contrast, you also have skin enhancement. You can have T2 hyperintensities, curvilinear, that represents the edema. That represents the curvilinear hypoechogenicities you can see at ultrasound. Irregular masses can be contiguous or can coalesce, grouped together into a big bunch. You can also have non-mass enhancement, and again, our associated finding of adenopathy. Now, I know that's a lot of words, so let's look at some images to solidify those words and what they mean. Let's look at a case of adenopathy. So this is an inflammatory breast cancer case, and where is the cancer? Is it the right or the left? Right. So here it is, and of course, what we're seeing, this patient had a palpable finding here in the upper, but really quite a diffuse finding with the skin. And of course, we have our important finding of adenopathy. On ultrasound, whereas we did not see a mass per se, on mammography, I would say that the breast tissue does not look that different on the right and the left versus the left. But clinically, she felt very different, and you can see that there is a big mass here. Hypoechoic shadowing, very classic cancer. This is a large field of view ultrasound, but if you focus on the skin, you can see that it's thickened, definitely more than 2 millimeters. And at MR, you see this really big abnormality on the side, the right side, compared to the left. This right breast, obviously abnormal and larger. You have this kind of global non-mass enhancement involving the entire right breast. That's much more than background parenchymal enhancement. Skin is thickened. You can see that on the MR compared to the normal left side, which is nice and thin. And often you can get prominent vessels right underneath the skin. Here's the sagittal view. You can see the nodular enhancement there, enhancement in the skin representing that dermal lymphatic involvement that makes it inflammatory breast cancer, stage T4D, as in dog, okay? Skin thickening, nodular enhancement. And then at ultrasound, you can see adenopathy. We saw that at mammography as well. And here's your adenopathy that has have some cystic necrosis in it. There it is. That's your node. And on MR, that axillary node is actually a whole bunch of nodes, and you can see the non-enhancing components, which is your cystic necrosis there in the axio, and there in the axio, and there in the sagittal. That's your axilla level 1. And then just to photographically enlarge for you to show you morphologically what they look like, including the non-enhancing cystic components, correlating that with what you see on ultrasound. And here is another location. Remember, locations are really important in adenopathy. And this is your internal mammary region on the right. And there it is, sagittal. There it is, axial, photographically enlarged. Again, you can see that cystic necrosis there in that node of internal mammary lymphadenopathy. And here's your PET CT. And this demonstrates the significance. Well, we started out by talking yesterday in the sense that breast cancer spreads via lymphatics, because here's your breast cancer on the right. That's your inflammatory breast cancer. There is your internal mammary adenopathy. But what is dramatic here on the right side in this PET CT fused image, right, breast cancer adenopathy, there's your internal mammary adenopathy, is of course this, which is your T thoracic spine metastases, and of course this gives the patient stage 4 disease. And that's why it's important that we take great care of these patients, because they are associated with bad prognosis. Okay, more cases. MRI definitely shows you more than at least mammography and often ultrasound. And you can see that on the mammogram here, another classic inflammatory breast cancer. Here the breast is relatively dense, but probably the most dramatic finding on this mammogram is what? What do you think? Skin a little bit thickened. It's better if I showed you the other side. But what's definitely abnormal here, even without comparison to the other side, is here in the axilla, right? Because this is definite adenopathy, regardless of what the other side looks like. You know, a lot of abnormal nodes. And we think, of course, cancer, lymphoma, or breast cancer. And in this case, subtraction image on the MR sagittally, you definitely see this coalescence, this conglomeration of multiple masses. The specific area where the breast cancer is, which you don't appreciate on the mammogram as much. And that's the adenopathy there on the MR. And here she is on the axial view. You can see these masses as a conglomerate, a whole bunch of them. You can see the skin thickening. You appreciate that, especially when you have the contralateral side to compare with. You can see the nodular enhancement underneath the skin. But of course, you have your significant adenopathy. Note that you have here enhancement of the pectoralis muscle, which is abnormal and which is involvement by tumor, but just remember that's different from T4A, okay? T4A is chest wall. Again, that's not only pectoralis muscle only, but actually chest wall structures. And here is your T4D. So that is you kind of take the highest amount of involvement, and T4D is the highest amount. So dermal lymphatic involvement is bad news. Okay, let's look at another case. That was how the power of MR, if you will. Here, look at, just ultrasound, which all of us have in terms of access much more readily. So this patient was a relatively acute onset, 1 week, right breast swelling and palpable nodularity. So right breast, okay. Do we see an abnormality? Well, yeah, she has a lot of skin molds. She has, possible masses. So let's look at what's happening. Adenopathy, maybe there's some structures there. Yeah, I think so. So let's look at it with ultrasound. Now, even with the mammogram here, you appreciate that the symmetry is not there, meaning this is asymmetric. The right breast compared with the left. The skin of the left breast is nice and thin. The skin of the right breast is diffusely thickened. And while I can't exactly pinpoint how much disease, I kind of feel like, there's some masses there. I don't know how much, though. Now, notice that this breast is not that dense, right? Maybe density category B, scatter fibroglandular densities, maybe. But in any case, this is a 90-degree lateral. This is the XCCL image, exaggerated craniocaudal lateral. And hard to say how much disease. Do you think there's like a 2-centimeter disease, 5 centimeter? A little bit hard to say. There is a mass, at least one. When you do ultrasound, this is one of the classic findings. There's thickened skin, in this particular case, measuring a little bit more than 4 millimeters. So this is thickened. But here is the ultrasound mass. Now, this is a classic cancer, right? You see this, you recognize this as a cancer. And so this is indeed your primary origin in the breast. It's irregular, it's anti-parallel. This was at 8 o'clock. And notice how good ultrasound is. It's just kind of defining everything. Here, there is abnormality that's also shadowing, extending to the skin. But turns out that she had surgery before at the similar position. This was a scar when you correlate with her physical exam, and this extends to the skin. So ultrasound was kind of nicely delineated for us, the scar and the relationship of the cancer near the scar, okay? Just to show you how, yes, MR is very cool, but don't forget ultrasound. Ultrasound is really a friend that is readily available to most of our practices. And really, the disease is great. Look at this. And here are the measurements of that disease, measuring more than 10 centimeters, and that was corroborated on at pathology at surgery. So it showed much more than what the mammogram showed. 10 centimeters, that's a lot. And then we have this. Is that a multifocal process? What's happening here? Okay, looks like another mass. Well, turns out in retrospect that corresponds to this structure here in the axilla, if you will. And at pathology, that turned out to be, look at this, everybody. Okay, so that turned out to be in the axilla nodal involvement with extracapsular extension, so giving that irregular look. So correlates nicely with Dr. Janicki's lecture yesterday on lesions in the axillary tail. Of course, differential is a tumor deposit in the right axilla, which is definitely possible as well. And so this required pathology to help us sort it out. Okay, we know it's an aggressive cancer with poor prognosis, and let me show you one such example where within a year something happened. And look at this particular case. The inflammatory breast cancer is where, right or left? Left, this breast, you all understand. The skin thickening, you know it when you see it. But notice that you cannot tell how much in the breast, right? Is it 1 centimeter or is it 6 centimeters? So if you're gonna follow these patients on neoadjuvant therapy, which they always get, it could be very challenging. So on T2 weighting on the left, just to show you the curvilinear hyper intensities, this is a lot of edema. And of course, on contrast enhanced, you see that there's a lot of non-mass enhancement, there's skin thickening, and look at all these little nodule enhancement in the skin. That's your dermal lymphatic invasion of inflammatory breast cancer. So subcutaneous edema, dermal lymphatic invasion, enhancement, global asymmetry, skin thickening. And her PET is on this side. That's obviously an abnormal PET, okay, with a lot of uptake on this abnormal breast and skin thickening. And by this time, though, she had mastectomy. So this abnormal breast, which is the left breast, is now removed, okay, mastectomy, no more there, and this is the normal right breast. I show you here because this is the baseline comparison for the next year, okay? Because this patient underwent neoadjuvant chemotherapy, had a mastectomy at this image. But then this is the initial when she had the left breast, and this is 1 year later after mastectomy, no longer the left breast. But what is the difference? Yes, liver. Dr. Ashraf, I hear him already. Yes, there's your liver metastasis. Not there in the liver dome initially. Unfortunately, even after her treatment and surgery, you see that liver metastasis, which is, of course, the problem, and that gives her stage 4 disease, okay? So that's a sad event, of course. And this is another sad event, advanced disease right at the onset. We can't even identify a focal breast lesion. So this is how this patient presented. How did she present, okay? She had a fungating tumor, was actually on the other side. This is the left breast. Her fungating tumor was on the right side, so much that we could not image it. Could not image it with ultrasound, could not image it with mammography, of course. And the left breast, look at that. You say, well, that's abnormal too, right? And chances are she has tumor involvement of the left breast as well, with the trabecular thickening, the skin thickening, the adenopathy now, you see suggested on the mammography in the left axilla. Her breast was rather engorged and large. So you have an MLO, you have a lateral, and I'm showing you two different depictions to cover the lateral and the medial aspect on the craniocaudal projection. And you can see the skin thickening, the trabecular thickening, just really abnormal. And this is the opposite side. When we go do ultrasound, she couldn't even lie down, really. She was so uncomfortable and have a hard time breathing when she lied down for her ultrasound. Sitting up, so left side, 3 o'clock. Skin thickening for sure. That's about 6 or 7 millimeters when we did the ultrasound. And then her nodes, right? The level 1 nodes. And this is, of course, also causing obstruction, which results in venous return obstruction and therefore more trabecular thickening. So that's level 1 nodes, really large and palpable. And then these are more level 1 nodes, multiple. I'm showing you level 2 nodes, just to show you a little bit of what our practice looks like. And then the level 3, a lot of adenopathy. And here you have an abnormal node in the supraclavicular region. Okay, so question, she has stage 4 disease. Is it because of this supraclavicular nodal involvement? Remember, stage 4, you need cervical, or as Dr. Ashraf so elegantly says, cervical. Okay, I like that. I say cervical. Okay, and yes, she does have stage 4 disease, but not because of the supraclavicular, even axillary level 1 in her case was stage 4, since this is contralateral disease. Okay, remember, contralateral is stage 4 even if it's just axilla. You don't need to be high up in the neck. And this is the concept of cross metastasis, going to the other side. It's particularly notable and common in cases of inflammatory breast, such that at MD Anderson, when we do imaging now, we include both nodal patients whenever we have an inflammatory breast cancer, even though they may not be as dramatic as this case. So we do both sides. So let's look at the presenting side, the right side, that we never had image of the breast, which is here in the axilla, level 1, level 2. And then we can't image her breast because she's really oozing fluid and fungating. But the chest wall, you get a sense there's abnormalities there, along the parasternal region. When you have Doppler, you see that there's increased vascularity with a lot of these little nodularities. And what you have in the parasternal region are these chest wall involvement that we could scan. Everybody see that? So that's all tumor infiltrating, really, really, really bad. Okay? And she couldn't really breathe. She could lie down because of this, which is a malignant right pleural effusion on the side. Just to show you the constellation of the dramatic aspects, which typically, we get a big reaction. But I understand in Egypt, too, that from my colleagues here, you see a lot of advanced cancers, too. So the idea is to prevent, hopefully, from going this far. Okay, so differential is mastitis. And here you have a case of mastitis and non-inflammatory breast cancer, skin thickening, you have some edema, this is infection of the breast. So challenge is that you can have infection and you can have inflammatory breast cancer, both at the same time. So the idea is if you think you have mastitis, treat it with antibiotics and follow the patient to make sure everything goes away and that you don't have an underlying component of inflammatory breast cancer. Remember that this is T4D, that's different from T4B, which is direct skin involvement. And this is an example of T4B, direct skin involvement. We know this because of biopsies of the skin and because of follow-up. So this patient has a large cancer that focally involves this lateral aspects of the skin right here at that spot. There is skin thickening, but not all skin thickening is inflammatory breast cancer. The rest of this patient's breast looks relatively okay. We believe that the skin thickening is due to this, which is axillary adenopathy that's bulky in the ipsilateral axilla that obstructs the fluid, the venous return. Okay, so other differential is radiation-induced skin changes or just edema of the breast in general from systemic disease, let's say renal failure or liver failure, okay? That gives you, or congestive heart failure, that gives you generalized edema. So of course, diagnosis, skin punch biopsy, and even though you do skin punch biopsy, you may still want to do imaging-guided, ultrasound-guided biopsy of particular breast lesions, because chances are, if you biopsy the breast rather than the skin, you are more successful in obtaining enough tissue for the biomarkers. ER, PR, HER2, which as you know, is ever so important to guide management and prognosis. Endocrine therapy, anti-HER2 therapy. Survival, it's poor without treatment. With treatment, it's getting better and better, but still not great. Overall, with some treatment, 30% 5-year survival, but multimodality treatment, 5-year survival rate up to 50%, and this number is increasing, but of course still poor compared to other forms of breast cancer. You always give neoadjuvant systemic therapy up front. These patients almost never go to surgery first, and the traditional chemotherapy, anthracycline, taxanes, but now we also have immunotherapy and also other targeted agents that are being investigated. An active area of research is against the epidermal growth factor receptor. I think that you all probably heard of the EGFR-related types of lung cancer that are now we see in non-smokers lung cancer that is somehow EGFR mediated, and there are agents against that. So similarly in breast, this is an area of active research. So very exciting. Patients usually get mastectomy and axillary nodal dissection, which means not sentinel node biopsy and not targeted axillary dissection. So they need a lot of stuff done because this is such an aggressive disease. And then they get radiation of the chest wall after mastectomy. But I leave here with the last thought is, axillary nodal dissection is not benign because you can have your complication of lymphedema here, okay? So at MD Anderson, what's currently being actively worked on is what we call de-escalation, doing less, if you will. So we're trying to see whether you can do less than an axillary nodal dissection. And this is a report from our surgical colleagues at Anderson in 2020 talking about de-escalation. So ongoing trials, the data is not out yet, but the point is that we want to be able to select patients that don't have to have axillary nodal dissection because that can be associated with more morbidity. And you can see in this one report is that trying to see which patients respond really well. So maybe they're the ones that don't have to have the full surgery. And in this report, 1/3 of the patients actually had pathologically negative nodes completely at surgery after neoadjuvant therapy. And the factors that will predict such great response are clinically no longer palpable and subtype, HR negative, HER2 positive. Okay, so that subtype particularly stood out. So all this is to say that this is exciting, going to personalized medicine and de-escalation of what we do with our patients, doing the most good with the least harm. Okay, so thank you very much. And going directly to the second lecture, which is on triple negative breast cancers.